So there's a question about genetics, and do we know if it's male or female origin? And the answer is no, and I think the genetic component is still poorly understood.
It's interesting in the U.S., though, that there's a preponderance of, there are many more women than men affected. And it's not that way in children in general. But in the U.S., it's either about 70% of people with symptomatic Chiari and Chiari Syringomyelia are women. But it's not like that in France, and it's not like that in children. So it's really not understood why women get it more often.
I have some biases on the subject. So, you know, this is a familial disorder, obviously. Lots of families have it. They've done numerous studies on the genetics, never found a mutation that correlated with these families. It has environmental components. It has components related to migrations. And nowadays, we are understanding, starting with cancer, but lots of other diseases, probably most diseases that are not obviously associated with a mutation, is that these diseases are related to epigenetic changes. What it means is that changes to the genes that can be inherited 3 or 4 generations, not hundreds of generations, and which are related to environmental factors. And the reason I think that a gene has not been identified is not because this is not an inherited condition. We're looking at the wrong set of factors. We're looking for mutations instead of looking for methylation changes to the genes or things like that. I think it's only a matter of time before this and spina bifida and a variety of related congenital disorders follow suit to a lot of the cancers, if not most of the cancers are now identified, that these are epigenetic problems.
Another question. Once you have decompression surgery, do you need to be followed on a regular basis? And are there specific signs and symptoms to watch out for? I think this probably varies. Probably everybody in the room does something a little different. I follow my patients yearly. I don't necessarily, once the decompression is done, I don't get MRIs unless we're following a Syrinx or something, and really go by clinical symptoms. And in my experience, I get worried is when the exact same symptoms you had before the surgery, they got better or starting to come back, that's when I'll get an MRI. I don't know.
If you have a Syrinx, well, the most important thing with any patient is what they tell you, really. I mean, if you have a scan that looks bad, but the patient says they feel 100% better, you wouldn't do anything anyways. But if someone says they're getting worse, and the MRI shows that the Syrinx after surgery didn't get smaller, then you have to consider the possibility that the surgery didn't work and that you might have to do a reoperation on that patient. With Chiari patients, and this gets back to the ASAP-supported Syrinx study that Dr. Iskandar is conducting. With a Chiari, no Syrinx, you really don't have anything to follow other than perhaps on the MRIs seeing some fluid behind the cerebellar tonsil. So it's much more difficult. You can use cine MRI scans, but if that looks very good, then you might think, well, with a Chiari patient, no Syrinx, that surgery went fine and you wouldn't reoperate. But if a Syrinx is present, the Syrinx is a good, what we call biomarker to follow to see if the surgery worked.
Question about tethered cord. If a cord's been untethered after surgery, can it recur, and is increasing pain a sign of recurrence after surgery?
So it depends on the type of tethered cord. As I shown you, there are multiple types. So for example, if you have a tight phylum and you go in and cut the phylum, the likelihood that the two ends of the phylum are going to reattach is is close to is 0. There could be a little bit of scar tissue. It's very unusual for that to retether, functionally retether. Whereas if you have a big lipomyelomeningocele, a big fatty mass that has been removed and the cord untethered, the chance of developing scar tissue in that area, which becomes like a spina bifida patient, where retethering because of scar tissue, that's at least 25 or 30%. So it really depends on the type of tethered cord that you have.
Here's a good question. How do you determine if you should have surgery with a Chiari with no Syrinx? And again, I think that's open to, I can tell you my practice is from what I described. I generally don't do Chiari decompressions for headaches alone. I look for neurologic deficits, weakness, difficulty with gait, walking, what we call long track signs. Syrinx becomes a more gray area. We tend to be a lot more aggressive with a Syrinx because those can expand and progress a little bit more quickly, especially a large Syrinx, because small Syrinxes usually don't cause symptoms, but as they expand and start to stretch those fibers, once you hit that point, there's a point of no return. So those I follow a little closer. I don't know what your cutoff is for.
My question to you, Erol, is if someone comes in with severe Valsalva-induced headaches, he's debilitated, can't go to school anymore, would you not operate on him?
I'll be honest with you. Have I operated on patients with debilitating? When I say
right.
I have, but I can count on my hands over the last decade where I have, because it's pretty rare. I think when most patients understand that, what I found is it's a fear that, well, these headaches and something bad's going to happen. The patient understands that you're not going to die from this, and that if you keep the headaches under control, and I'm fortunate because I have a great headache center. So the patients that the rare patient that I will relegate to is truly debilitating. And I'm probably on the other end of the spectrum, and I'll tell you why, because I'll tell you how many patients I have that come to me with headaches with Chiari, and their headaches are taken care of, and they don't need surgery. So, to me, you really have to prove that it's completely debilitating, and that there are those patients.
And debilitating is the term, and I.
But that's a very subjective term. What debilitating to, you know what I mean? I mean, like, you literally can't work. You've been, you're going to lose your job. Right. You've tried multiple regimens of pharmacotherapy and things like that. I take Tylenol, it doesn't get better. I don't like taking medicine. That's just my practice.
No, I mean, it has to just logically follow 2 criteria. It has to be a typical headache that you would expect with a Chiari, not a right frontal headache and photophobia, but typical Valsalva-induced occipital headache that has resisted any medical therapy, that has gone relatively long term, and so I can't say I don't operate on patients with headaches. I do. But I do have very strict criteria.
Yeah.
And usually you follow them over time.
Right. And we've all had, every surgeon in this room has seen the patient who's had classic migraines and comes to you and they've had a Chiari because a neurologist diagnosed them with Chiari, and they have Chiari and MRI, and they have classic migraine. And they had surgery. And guess what? They're coming to you for a second opinion because my headaches didn't get better. And I was told that's the first thing that gets better. So I think we're saying the same thing. But I think if you dissect out all the headaches and that's the only symptom, you get down to a smaller core. But of course, yeah, I mean, somebody who has truly intractable headaches. But I just think in my practice, and everyone's practice is different.
And it's different between adults and kids.
Absolutely.
I think there's a disconnect between the disease of Chiari 1 malformation and the radiology of Chiari 1 malformation. In other words, the radiologist says 5 millimeters of tonsil, the cerebellar tonsils being low 5 millimeters, then that's a Chiari. But that person might have no symptoms at all. They could be asymptomatic. And then you could have someone with less than 5 millimeters, if things are tight enough, called Chiari 0 malformation. They could have a Chiari headache, and if you showed a neurosurgeon the MRI scan, he'd say, well, it's very tight. That could be, but the radiologist wouldn't call it a Chiari malformation. So the disease of Chiari is the cough-induced headaches, brainstem symptoms, cerebellar symptoms, diplopia, sleep apnea. Those are things we can sink our teeth into. Those are the neurologic symptoms. So that's a disease. That's something that makes a person abnormal, and we can see it. If it's just a MRI finding, it's not a disease. It's just a MRI finding.
Right. And to that same, someone wants you particularly to address arachnoiditis.
Because cause of it, or
Just address it. No, I mean, just if you can just speak to it a little bit as far as what is it?
Okay.
You know, what do you?
Arachnoid means spider, and so now that we put spiders in, but there's a thick membrane, and that's thick. That's called dura, which means tough, and then the membrane inside that is called the arachnoid because it's spidery. You know, it's fine, and inside that fine membrane is spinal fluid. So if I had meningitis, I had a lot of pus cells, and the body would try to heal itself, it would create scar. If I got in a motorcycle accident and my spine was twisted, then the body would try to heal that by creating scar. And in that area, but after a short period, the scar would be gone. So even though there's an itis with it, the inflammation doesn't continue. The inflammation occurred at a short period of time, and now you have scar in the area where the trauma is. And if meningitis, if I had meningitis that affected my head and my whole spine, then that would be diffuse arachnoiditis. There's no way to do an operation and take care of that with a short operation. So then you might have to use a shunt to drain the syrinx. But if it's a small area of arachnoiditis or inflammation, old inflammation, then you can do a surgery, and since the trauma is not occurring then, you can cut the scar, the arachnoiditis, and improve the situation and hopefully make the syrinx go away. But arachnoiditis comes in all different sizes, and the big difference is a process that causes inflammation top to bottom, then that's something that needs to, you'd have to treat the syrinx, whereas if it's just a focal, very isolated process, then the direct surgery in that one area can be helpful.
That's a good question. How likely, from a data standpoint, a patient with Syrinx, I'm sorry, a patient with Chiari who does not have a Syrinx, how likely is that patient to go on to develop a Syrinx, percentage-wise?
I think Dr. Keating has, he's working on that.
Oh, you said that's a punt.
But see, with epidemiology, there's all sorts of ways to look at things. And so he has, that's what's called period prevalence, right, Bob, isn't that? And so that's for 4 years. So then you think, well, so you multiply 4 years by 5, and then you see how they do in 20 years. But till he follows them for 20 years, you're not going to know, you know. So that's our best guess. But 1 out of 20 for 4 years.
That means we don't know. It's the minority. It's like the best saying that there's, I forgot, I don't know who's quoted with this, but statistics and data are like a bikini. It's important what they don't show. But it's important what they don't show, but even more important what they do show, or the other way around, but you get the point. This is kind of what precautions, and you're going to get a different answer from every one of the doctors, which means it's a good question, because that means it's confusion. What are the precautions that should be followed if you have a Syringomyelia or Chiari? Are there any sports that can worsen symptoms? So generally, what is your precautions? And I'd imagine that's different for pediatrics and adults. And
I'm going to let Dr. Iskandar discuss the sports, but I'm going to just discuss one thing that I see adult women frequently, and they're concerned if they have Chiari, what they should do for childbirth. You know, most of them would go to high-risk OB if they don't want to have a decompression. But if they're symptomatic and they're just contemplating having children, that would be, and they're symptomatic, that would be one factor we'd take into account in decompressing before.
The short answer for sports is nobody knows. You go to various pediatric neurosurgeons, you'll find that the ones that let their patients play football are the ones at the Big Ten schools, except for me. It's really a matter of judgment. What I tell the families is that there's really no evidence one way or the other, knowing that that these sports, some of these sports tend to be quite significant in terms of they're causing concussions and neck injuries. I could think that maybe having a congenital problem added to that may put someone at higher risk, but we don't know. So I leave it to the family really to decide. And they can use this as an excuse to not let their child play football.
And you have to look at symptoms too, because I remember a patient who went to college on a scholarship, and he was a defensive back, and he tackled somebody, and he felt numbness in his arms and legs, and had a headache after that. And he was 150 pounds, so he's a little undersized, and he said, well, I don't know if I'm going to have the surgery. But I said, well, I don't think you're going to want to play football again. And he had a good grade point average, and we sort of concluded that he wasn't going to the pros, and so he had the operation. He's done fine. So, I mean, we have to do things on a case-by-case basis, but if it's symptomatic and it's caused by the sport, I think most people would say don't do it. But if nothing's come of it, then you don't know.
Yeah, my practice is if you have a Chiari that's not treated and/or Syrinx, I basically limit you to no contact sports and avoiding things that are going to give you a whiplash type injury. And as Dr. Ringer mentioned, no chiropractic manipulations. Other than that, you live your life. If you've been treated and the residual's gone, I do whatever you want. I'll release kids back to sports. I'll, after a period of healing and everything, because the Chiari at that point, that pressure differential is taken care of. And again, I don't know if it's a right or wrong answer, but you have to put yourself in the position of especially the child, high school, junior high. I mean, those are formative years, and to take someone out of sports or take someone out of what's making them normal, that's a big step. So you really have to weigh those two things. There's a question about girdle pain that someone wanted me to define what girdle pain is. It's kind of this mid-thoracic, and the person that wrote this said that they have really bad pain there. No one knows what's going on. Make sure you're getting an MRI of your thoracic spine. So that's sometimes something that gets missed. We tend to go from here to here. Even patients who have a Chiari, you don't have, if you're having isolated pain, especially kind of in a ring-like distribution or girdle-like distribution around your ribs, you need to get an MRI to make sure you don't have a Syrinx, because that's kind of the classic presentation for that, and it's not infrequently missed. Let's get, some of these are duplicate here. If a child has a hairy patch and some leg lengthening discrepancy and a sibling with Chiari and Syrinx, should that child be tested? I think that's a...
Any child who has a hairy patch without anything else should be tested. The question, though, is to separate that from just regular baby hair. If you're a little Italian child with lots of... That was intended for you, Paul. But that's really the difficulty in distinguishing between them. But a true hairy patch is coarse. It's almost, it's coming out of the back and in a location that you wouldn't expect, and that's the bottom line.
Fatty phylum and connective tissue disorders with occult tethered cord, new MRI protocol, supine prone show that the tethered cord's not so occult. I guess the point of this is that more and more MRIs are being done and showing that it's more common. I'm assuming that's, I don't know, Esther, if you're seeing more of that. Or
There was a study, it was either from Japan or Korea, where they did supine and prone MRIs. In other words, most of the MRIs are done with the people on the back. And when that happens, if you have a tethered cord, the phylum, and the cord falls back, and you see the phylum in the back, and you don't know if it's in normal position, but then you turn somebody on their belly, and then if it truly is tethered, the the spinal cord should still be held backwards. At least that was the theory. But that's gone back and forth. But this one group found that that was an important way to do it, but people are skeptical. I mean, that was after 5 other studies showed it wasn't important, so it's controversial.
So there's a couple overlapping questions here about Syrinx and Chiari and the appropriate resolution, and how long should it take to after surgery to go away? Is having a little bit normal still there, like everything's great, but on the MRI there's still tiny Syrinx, and also residual pain. Even though the MRIs look great and everything's going in the right direction, but there's still pain there, and that's something I think we see not infrequently.
Yeah. Okay. Yeah. The thing is we looked at our results, and there wasn't really any difference between people who had their Syrinx go away completely and people who the Syrinx went away, but not completely. The most important thing is the spinal cord have a diameter that's less than or less than normal size. If the spinal cord's distended, then something is still going on. The problem with syringomyelia is it damages the inside of the spinal cord, and the damage isn't repaired by the surgery. And so people with pain, for the most part, it doesn't go away with surgery, and it's hard for people to understand. It's like, I had surgery, I had pain, and then I had surgery, and I still have pain. But the objective of the surgery is to keep you from getting worse as far as paralysis, numbness, and more of the spinal cord being affected. Most people after surgery have a little improvement in their pain. Some people, right after surgery, I think it's because the Syrinx is collapsing and there's this process of healing inside the spinal cord. It's not growing new nerve cells, but just the process, whereas some scar tissue forms. An occasional person will have more pain right after surgery as the Syrinx collapses. I can't really explain it, but that can occur. It doesn't happen that often, but it can occur.
Yeah. This is a completely separate thing. I'll be Dr. Oz here for a minute. So someone's asking, they were walking off steps and they banged really hard and they kind of had some, what we call, I guess in sports, a sting or some abnormal sensation in return. It's nothing to worry about. If it persists or it gets worse, then, but that's literally, it's kind of a concussion of the spinal cord, so to speak, and it happens in football more frequently than it should, but it's what we'll call the stinger, and watch your step. This is a good question. This is open to everyone. Would you classify Chiari as a disorder or a disease? I always tell the good questions so everyone starts looking away. I guess it depends, right?
Well, a disease is...
This is definitely going to NIH. You got to answer that one.
Well, I mean, a disorder, if you consider a disorder as a malformation, it is a malformation because the brain is malformed, so it doesn't look the same. Is it a disease? It's a disease if it causes a certain disability, some form of disability or dysfunction of a physiologic function, such as sensation, movement. So it can be, but if it's just, as we pointed out, if it's just a finding on the MRI, then it's not a disease. They did a study in Holland of normal people, and they found that Chiaris were found in 0.9% of adults. And there's also a lot of other bad stuff that's found. You can find people that have small strokes that they didn't anticipate, aneurysms, a lot of asymptomatic aneurysms. So if you get a scan, you're going to find some stuff. But these people were all healthy, asymptomatic adults. So there's, in almost 1% of people who get scans, you're going to have the 5 millimeters of ectopia, or the tonsils are going to be down enough to qualify as a Chiari. So, but as the tonsils go down further, you're more and more likely to be symptomatic. So it's a disease when it affects your function, and And that could be symptoms, or it can be something that we find as neurosurgeons. Go ahead, Paolo.
Paolo?
Some of the European colleagues in the field, actually, in order to tackle this problem, they introduced the term of Chiari Anomaly, which is kind of one way to put it.
Yeah, that's actually a good point. Chiari Anomaly, yeah, because it is an anatomic anomaly with corresponding. So there's I guess this is referring to my comment about Chiari won't kill you. 10 to 12 deaths per year in the U.S. are from people going to sleep at night and not waking up. It's very important to differentiate. Chiari didn't kill. First of all, what is all we can go by are what data we have. So I don't know if any of the other physicians are aware of any data. Their sleep apnea is definitely a correlate. Those patients died of respiratory distress. It's not the Chiari. Chiari may have exacerbated. The point I was trying to make is that Chiari in of itself, you're not going to be walking and standing and all of a sudden just stop breathing and die. If you have other symptomatology, you have other disease processes, can it make it worse? Absolutely. Just like doing something, having a chiropractic manipulation with a very severe Chiari is going to make it worse. And it was, I think, the same thing came up with SIDS, and I think Dr. Keating answered that. He looked it up. Chiari is a very easy thing to put pin the tail on the donkey, and it's a Chiari. And the classic is a car accident. You know, what came first? So that's the point. Not that it's not belittling it in any way, shape, or form, but those are, Chiari didn't kill those patients. It may not have helped. Sleep apnea, respiratory distress is what kills patients. And I'm not aware of any of that data. I don't know if you are.
Tim George published a paper years ago, just a case report of a child that died after from a Chiari-related apnea. I've seen 3 kids that had asystole that improved with or resolved. 2 of them resolved, 1 improved after Chiari decompression. And if you look at Arnold Meneses' series of less than 4-year-olds, the most common presenting symptom is oropharyngeal dysfunction and apnea. So there is a correlation. Like you said, it's very rare, and it's very difficult when you look at retrospective reports to draw a cause and effect. So we don't scare patients. I also, in my notes, say it's a non-life-threatening disorder. I said it in every note just because, you know, the 99.999% of patients are not going to have this problem, which is a much better odd than driving on the freeway and getting killed in an accident. So,
Yeah,
but there are reports that...
Yeah, of course, there's case reports, you know, for everything. There's case reports for, you know, incidental AVMs that haven't bled, killing people from status epilepticus. And so, you know, the point of it is first and foremost to not scare patients and not, you know, not belittle it. The same point being, and I tell my patients who've had ruptured aneurysms and strokes all the time, if you know someone who's suffered a severe stroke, there are fates worse than death. You know, being debilitated for the rest of your life, you know, being in a nursing home at a young age, not being able to speak, you know, so it's, again, it's not saying, sometimes symptoms are worse than the ultimate, but the point is that this is not something, to your point exactly, this is not a life-threatening. It can be a life-altering, very, very rare. The data we have are case reports, and you have to kind of put 2 and 2 together, and I would say that more times than not, these are kids who are presenting with drop attacks, already have known asystole or having other symptoms. If you have that and that's ignored and ignored, yes, that can be lethal. We're talking about patients that are incidentally found. Did you, Paul?
The majority of the adults that I knew directly who died and they had a former diagnosis of Chiari malformation, the majority of these adults had a combination of sleep apnea and very elevated consumption of opiate drugs. So, and painkillers.
Yeah, there you go.
So you have the patient who was a chronic patient with a build-up tolerance. Very often there was a component of self-medication in excess to what the doctors were prescribing. So you have a patient who, a combination of depression, sleep deprivation, etc., pops the extra pill, and that makes him, you know, stop breathing in the middle of the night. That's the vast majority of the patients who are adults. Again, the pediatric patients are a completely different.
Totally different, right. So we'll kind of end that conversation with this. You're more likely to die in a car accident than you are of a Chiari malformation. So I can put that in context. If you have a syrinx that's not caused by Chiari, will it resolve on its own over time? It depends. And I think it depends if it's traumatic, it depends how long it's been there, it depends where it is, and it really depends on the cause.
I've seen people who've had herniated discs, and the discs get a little smaller. The discs are between the vertebrae, and sometimes I thought, well, this person should be operated on, but they have a heart attack and they have surgery for that, and so they put it off for 6 months so they get another scan, and the syrinx is better. So if the compression of the spinal fluid is reversible by the disease process, in other words, sometimes you get a herniated disc, and then over time it shrivels up like everything as it gets older, like me. So, anyways, it's but the disc will lose water and it will get smaller, and then the spinal fluid will circulate a little better, and the syrinx will get smaller. So it's just a matter of what the underlying condition is. If the underlying condition can resolve and leave no scar, then the syrinx can get better. But that's a sort of a rare case. If it's due to a cyst or a tumor, something that wouldn't get smaller on its own, the syrinx wouldn't go away.
Do you hear patients who complain of facial teeth pain? I have patients who have hair pain, and to put in context, there's no nerve endings in the hair. So yes, it's a chronic pain, and I think we've seen probably every form and variant of pain. Again, that's real, but what's correlated, teeth, I think less common, but facial, yes, especially with a high cervical syrinx and severe caudal herniation. So I think it is something you can see. Syringomyelia in the thoracic, can it cause feet cramps? Yes, because if your muscle is atrophying there, if you're having spasms, you can absolutely have that. Generally does not cause circulatory problems. And putting a shunt in the spine, does it cause pain? No. It should alleviate pain, should be the goal, and alleviate the syrinx. Can it make it worse? Absolutely. If there's nerve root irritation, any surgery, no matter what it is, can leave you with more pain than what you started with. And can it cause damage on the organs, syringomyelia? Other than what we talked about, no. It doesn't have any effect on your kidney, your liver, or anything else. Do you guys have any different?
Well, you can get anybody with paralysis, you have to be really careful with your bladder control, because you don't want to get bladder infections.
Right, so bowel bladder symptoms, but...
You could, however, get, of course, ulcerations and insensate areas in the feet, and that could create infections, that could create kidney problems. So, but that's pretty unusual. It has to be pretty debilitated for that to happen.
Here's a great question to end with. So, to piggyback on Chiari and Syringomyelia prevalence rates in males and females, do you believe there's a cultural component in males to try to fight through the symptoms more often than females? Now, I know a woman wrote this, so a man would put it in the other way around. But it's a very good question because, to your point, John, there are clearly differences among cultures and among ages, and so do you think that there is some component of that? Men are from Mars, women are from Venus.
No, I don't think so. I don't really understand why, but their syrinxes are large and they have typical Chiari malformations. So it's not that they're less tough than the men.
I think in my patient population, women smile more, they go home earlier, and they have much better results in general. I think they're just better human beings.
His wife's in the audience, by the way. She's in the back, so he's... That's so we can stay out late tonight. So great questions, everybody. All right, well, you guys enjoy a well-deserved evening. If you haven't been to downtown Princeton, go. It's a lovely place. There's great cafes, restaurants, and just even walking around the Princeton campus, it's absolutely beautiful, and I think it's a nice day. So enjoy your night. Don't get in trouble at the bars, and we'll see you tomorrow morning.